HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I'll be speaking to Specialist General Practitioner and Sports and Exercise Medicine Registrar, Dr. Jason Lamb, and Sports and Exercise Physiotherapist and Clinical Pilates Practitioner, Leanne Scown. We'll be talking about Ehlers-Danlos syndrome and hypermobility spectrum disorder and the management of pain related to these conditions in general practice. We're going to discuss the prevalence of these conditions, their key features, pain management strategies, and how, as GPs, we can best support our patients with EDS and HSD. So Dr. Jason Lamb is an ex-professional dancer who then studied medicine, had a detour through surgery, then gained his GP fellowship and is now working towards a fellowship with the Australian College of Sport and Exercise Physicians. He was the Crichton Dance Medicine Fellow at the Australian Ballet, and his clinical practice is split between hypermobility, POTS, mast cell activation syndrome, long COVID, chronic fatigue syndrome, and other diagnostic conundrums, as well as minor procedures, sports medicine, and in particular, dance medicine. He likes to have his fingers in lots of pies with interests in dinosaur-based jewellery, filmmaking, public speaking, entrepreneurship, and he's also involved in research. And Leanne Scown is a Master's Qualified Sports and Exercise Physiotherapist and Clinical Pilates Instructor with 21 years of experience in private practice physiotherapy. She started working at Dance Medicine Australia in Melbourne, then the Olympic Park Sports Medicine Centre in Melbourne for 15 years, and she now works exclusively in Geelong under the banner of Leanne Scown Sports Physio. 95% of her caseload is people living with hypermobile EDS and the party bag of tricks that comes with this condition. Both Leanne Scown and Dr. Lamb's roles include sitting on the Connective Tissue Disorders Network Australia's Scientific and Medical Advisory Committee. CTDNA is the national peak body representing the healthcare needs of Australians with heritable connective tissue disorders. Jason and Leanne, welcome, and thank you for joining me for today's Health Ed podcast. Jason, to start off, can you please give us a brief overview of what Ehlers-Danlos syndrome and hypermobility spectrum disorders are?
Yeah, sure. Thanks for having me. So Ehlers-Danlos syndrome are a large group of heritable connective tissue disorders. There's 13 which are defined so far, and they're caused by genetic changes that affect connective tissue. And there's lots of different versions with which have their own set of distinct features and diagnostic criteria. Common to all of them is going to be some degree of hypermobility and skin hyperextensibility and tissue fragility. And hypermobile EDS, which is probably the one we'll kind of focus on today, is one of those. And it's the only one which isn't currently defined by a genetic marker yet. We don't know. We think that it's likely to have some epigenetic and gene environment interactions. And we've kind of seen that certain symptom complexes appear after trauma or after a significant change, like hormonal changes, life changes, hormonal changes throughout life and that sort of thing. So there's likely going to be some epigenetic sort of components to it. Hypermobility spectrum disorders are connective tissue disorders that cause joint hypermobility, instability, injury, and pain. And to be honest, they're probably good. There's a huge amount of overlap. You know, the diagnostic criteria for hypermobile EDS is an arbitrary line in the sand. We were using the Villefranche criteria, and then in 2017 that changed, and it's going to change again next year. And where hypermobility spectrum disorder and hypermobile EDS kind of cross over, it's clear in the diagnosis now, but like I said, it's an arbitrary line. We don't have a diagnostic biomarker. And so I guess that's one of the really important things I'd like people to know is that one is not more than the other. Hypermobile EDS is not more severe than hypermobility spectrum disorder. They both can affect multi-systems. They can have varying degrees of severity in multiple different domains. And that kind of tick into a hypermobile EDS is really, at the moment, based on a arbitrary clinical sign. And even we see now is it can be operator dependent even.
We'll talk about the key features of them both in a moment, but Leanne, could you tell me how common are these conditions in the general population and why might they be under-recognised in primary care?
The incidence at the moment is, as Jason said earlier in our conversation, it depends on what you read. There is the published data in that regard from different sources that the EDS Society, for example, does state that it's 1 in 5,000. And then there's other more sort of prospective sort of studies or groups of people that feel that due to the underdiagnosis and the underrecognition of these conditions, that it could be anything up to 1 in 500, which makes it not rare. It's actually quite common. The problem is that it's rarely diagnosed, if that is in case the incidence. So the second part of your question as to why it might be underrecognized is, from my perspective, I can say that there was no formal education around heritable connective tissue disorders when I went through my undergrad 20-something years ago. It's something that I've learned on the fly whilst I've been working, and then done the deep dive into learning more as an area of interest. So I think there's potentially a lacking component to this through the educational process within allied health and potentially the medical world as well. And perhaps also the fact that it does cross so many systems is that there's no one domain of allied health or medicine that is the primary sort of oversight in this regard as well. So it's an area that, why we're here, I guess, to educate people and make more practitioners aware.
Well, Jason, could you then tell me what are some of the key signs or symptoms that should prompt a GP to consider hypermobile EDS or hypermobility spectrum disorder in their differential diagnosis of a patient?
My tongue-in-cheek one would be if the patient reckons they have it. They are often way better informed than most of us because, like Leanne said, we didn't learn about this in medical school. We didn't learn about it in our GP fellowship. It's not really touched upon in any curricula, really. I think the rheumatologists maybe have a smidge. We as a profession are bad at recognizing it, and we've all seen it and we've all missed it, myself included. And as I guess, as Leanne said, because it's multi-systemic, it covers so many things, and it makes sense because there's a disorder of connective tissue, and we are mostly connective tissue, and it affects everything. So things people will commonly present with is going to be pain, can be recurrent injury. We do find that people with hypermobility type disorders often frequently injure themselves, and they're kind of clumsy. The proprioception, and Leanne can definitely speak more eloquently to this, can be a little bit dodgy, and dyspraxia, and so they tend to, they bump into things or they trip stuff. And then when they do, they tend to injure themselves more than you would expect. So really commonly, like patella will sublux, shoulder sublux, frequent ankle sprains. But really interestingly is, gastrointestinal complications are really common. And actually the American Gastroenterologists Association recently just released the clinical guidelines to advise gastroenterologists to look into hypermobility if people present with a DGBI, a disorder of the gut-brain interaction, which we know as GPs is one of the most common things we see. I mean, we always just go like, you've got irritable bowel. But actually the AGA is now saying, consider hypermobility as part of this, because it may present with irritable bowel-like symptoms, with pain, with rapid or slow transit, fecal impaction, nausea, all these sort of things, and as well as that HOTS, which is the other one which always pops up. So autonomic dysfunctions, so problems standing up. It's like, I get really dizzy, I've been standing up for a long time, or I get really fatigued, brain fog, and I feel a lot better lying down, or my heart's racing. So it covers so many things. So I think it's really key for us is to keep it in the back of our minds. There's that whole Occam's razor and Higgins dictum sort of thing. Occam's razor is the one overarching diagnosis, or Higgins dictum, they can have as many diseases as they damn well please. But do they really have, 16 different diagnoses? Maybe it actually is hypermobility kind of underlying it. So and the other thing that I'd like to mention is that there's a huge overlap with neurodivergence. So somewhere up to 70 odd % of people with ADHD, 50 odd % of autistic individuals will have EDS or hypermobility. And one, as you know, as a practicing GP, often these individuals will have physical illnesses and they may express it differently. So keeping it in the back of the mind as a possibility.
And I imagine that patients may wait years to actually get the diagnosis of EDS or hypermobility spectrum disorder, and they may have had lots of different symptoms and no one's put it all together, as you suggested, with one overarching diagnosis. Can you talk to me about whether genetic testing is important to get to the diagnosis, or is this a clinical diagnosis? Do we need to involve geneticists, rheumatologists, or is this something that GPs could have in their mind and then actually make the diagnosis themselves?
So that's one of my passion projects is yes, GPs absolutely can. And I think we are actually really well placed to do that because we see people across lifespan. We see people across multi-systems. We are not a single organ specialist. And it is a clinical diagnosis. It requires that you rule out, concerns for the monogenetic forms or severe rheumatological type conditions, but it's very clearly laid out in the 2017 diagnostic criteria, which you can get on the Ehlers-Danlos Society website. And for people under 18, you can't actually get a diagnosis of hypermobile EDS. It's pediatric generalized hypermobility with or without certain features, so systemic subtypes and that sort of thing. But they're very clearly laid out, and there's a really nice flow chart which will take you through that. And my colleague, Dr. Megan Thomas, has an article out in AusDoc, and I will also plug my own article, which is coming out shortly. Apologies, it is very late, which help people, which are designed to help GPs go through this. There are certain features where you want geneticists involved, like if there's a really strong family history, or really severe features. So I work closely with Dr. Kunal Verma, who I believe has been on this podcast. So yeah, things like severe skin fragility, severe ocular problems, like easy fractures, just that shouldn't have caused fractures, severe scoliosis, sudden cardiac death or aneurysms in immediate family, dissections. Yeah, those sort of things are where, a genetic referral is appropriate. But if we don't have those things, then yeah, I think GPs are very well placed to assess, to diagnose, and very importantly, to manage. And that was probably my other thing that I'd love people to take away is like, okay, even if you think you want genetic backup or rheumatology backup, that can take ages. We can actually start managing people now. Why wait? The earlier we recognize and we start treating, the better the outcomes are. And getting people allied health, who are really the heroes and the mainstay of this, like Leanne and all our wonderful colleagues, that's really key.
And I imagine it must be very validating for a patient who's had perhaps years of musculoskeletal and GI symptoms and fatigue to actually finally learn that there's an explanation for why they're feeling like this. And then, as you say, to be able to commence management with the appropriate allied health specialists and their GP as part of the team. And also, I guess, to address their pain. So, Leanne, pain is a major issue for many patients with these conditions. So could you explain the different types of pain that these patients experience and what is the driver for the pain they do experience?
It's a big question. I mean, pain in itself and the differentials on pain is a whole master's course in itself. I guess most of us have an understanding of pain as a protective mechanism, so associated. So your nociceptive base pain, which is your injury, your rolled ankle, your sublux shoulder or patella. Layered in on top of that there's an inflammatory pain as well. And in this population group as well, which I don't think has been mentioned yet, is immune system dysfunction as well, which often goes hand in hand with this group. So MCAS, mast cell activation syndrome, is, I would say, most of the time, based on my cohort, I can't think of anyone that doesn't have at least some degree of immune system dysfunction that can often essentially turn the dial up on something that might be an injury or again, they pulled their doona cover up and they dislocated their shoulder. There can be an inflammatory response that is amplified by the fact that their immune system is playing games in the background. And this is where the GP management, especially in that realization that this is their story, managing or at least targeting the MCAS side of things, in my experience, can make a massive difference to their day-to-day life and their capacity then to do what I am throwing at them in terms of exercise-based interventions. Neuropathic pain is more sort of what most people think of, I guess, as more nervy-based pain symptoms. So burning, sharp, that sort of language that people will often use around, which is more associated with, I guess, the biochemistry associated with our nervous system, but can also be layered in with the mast cell dysfunction. And then there's a central sensitization that is, again, if we're talking really black and white, and all these elements of pain overlap ultimately, and everyone's experience of pain is different depending on context, environmental exposure, what impact it has on their day. But there is often in this patient group the label that their system is sensitized and they just need to positive mindset their way out of it. And that's a really simplified way of where I think in a physio space, the pain education, etc., has gone, which can be really traumatic and can be very invalidating for these people as well. So it's, to answer your question, I guess I think I covered most things, because these people will present with multi-regional pain from injuries that are atraumatic or incidences that are atraumatic, or sometimes they don't know why they're sore. And sometimes there's a tissue basis to it, but it's often layered in with their immune system as well. And then I think there's a lot that we don't know about this domain with this patient cohort as well.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
So, Jason, how could GPs approach the assessment and the management of pain in these patients, particularly when, for example, if you order imaging, there may not be a clear cause revealed for why they might be experiencing pain?
Yeah, sure. So, I always teach my registrars this. Imaging shows structure, not pain. That's, very clear in all the research. Structure does not equal pain. So the role of imaging is really to rule out if there is a significant structural thing which may require more intervention, but there usually isn't. That doesn't mean they're not in pain. And part of my explanation of it, kind of going on with Leanne's, is that pain is the body's protective system, and it's a predictive system. So if you have recurrent subluxations or something like that, even if it hasn't subluxed, any sort of like movement or threat to that, your brain is going to be like, oh, the last time that happened, it's going to try and protect that. And by doing that, can have a pain experience. And then to try and protect that, it'll try and tighten up all the muscles to try and hold in place, because the soft tissue, the ligaments and tendons aren't doing their job terribly well. And so you've got this other source of potential pain with all the muscles overworking to try and do this huge amount of tension. And as she mentioned, there's, immune dysfunction is huge. And so, and I probably explain central sensitization more as a neurohormonal immunosystem kind of all ratcheted up. And MCAS plays a role in this. Our immune system and pro-inflammatory type things are kind of wired. And so relatively innocuous things result in pain. And even for many people, like the simple act of keeping their head up and stable causes pain. The craniocervical instability, classically, a lot of people describe this coat hanger pain that's often worse when they're in a car and often as a passenger, because it's an unpredictable movement. And so they're kind of like trying so hard to stabilize, and everything is overworking. So, the treatment for this pain is, well, is recognizing that pain is real. Just because you can't see it doesn't mean it's not real. The experience of pain is absolutely real. Then we have to look into what are the particular contributing factors. And, an absolute mainstay is working with a physiotherapy with expertise in hypermobility, who understands how to work with hypermobile individuals. It's not quite the same, and Leanne will definitely talk about this more. It's not the same as working with your average person. The way they respond is different. The way you treat is different. You definitely. I always tell them, you don't want high velocity manipulations. And excess. Often because they'll complain of tightness. Excess stretching is actually not going to be helpful. The tightness is there because they're trying to protect themselves. We loosen that too much, it's just going to fall apart. And so it's getting that balance between, tension and relaxation and all that sort of stuff. As Leanne also said, if we can calm down the immune system a bit, with mast cell activation, which is kind of going outside our scope, but actually really simply like antihistamines. Over-the-counter antihistamines can often make such a huge difference. And that just dials things down. We know that mast cells live at the interface between the world and us, so skin, lungs, nasal passages, gut, and also they live next to nerves and blood vessels. And if they're inappropriately sensitive and kind of drop their bundle of their chemical mediators, that ratchets up inflammation and pain. And things like antihistamines and the H2s, like famotidine, nizatidine, can be really helpful, and they can just like dial that down a bit, and that all contributes. We know that trauma also plays a role in that kind of ramping up of the neurohormonal sort of system. So actually, yeah, you're right. Actually, they're getting that diagnosis and getting the right team. That already brings a layer of safety and can help reduce that anxiety, because they've been so used to fighting us, fighting the system, trying to be believed. Even just making that shift can drop that down a bit. And then we've got all the other tricks. So often I use, low dose naltrexone, which is becoming more common, low dose amitriptyline or nortriptyline. We know that small fiber neuropathy is more common in this population and can be a cause of pain. Interestingly, I've seen quite a few of B6 toxicity, because for some reason it's been hidden in everything, and that can actually present as a small fiber or peripheral neuropathy, and actually just calming that down can help. Speaking of small fiber neuropathy, no one does the biopsies. It's coming up on social media a bit. It is a thing. We kind of diagnose it clinically. There are very few places outside of research which will do that. To be honest, it doesn't really change things. We can manage it with things like low-dose naltrexone, amitriptyline, some of the gabapentinoids and that sort of thing. Yeah, and then, calming down the gut, like calming everything down, optimizing everything. I do tell people I can't fix their problem. They're like a bicycle tire with lots of holes, and the game is to plug as many holes as possible.
Okay, good approach. And so, Leanne, what is your approach from a physio perspective with these patients?
Definitely, as Jason said, it's a different approach to your footballer or someone else that I might see in a sports medicine context. And often these people will have had a bad experience, and with whether it be physio, osteo, chiro, whatever sort of manual therapy based practitioner they've seen. And so therefore they come to the conclusion that it's not helpful for them. But it is really genuinely about finding someone that understands how to approach them and move them forward. So it is, from a manual therapy perspective, it is much more nuanced. It is about listening to what's going on under your hands, which I feel like a lot of manual therapists have lost that skill typically. And I'm generalizing, it is a much more gentle approach with your hands, because it is that often their system is, their joints, their ligamentous structure is not as robust. Their muscular system has to compensate for that. That can often end up, as Jason said, in that spasm guarding response. You take that away too aggressively and their system literally feels like it has nothing. It will just ramp up that muscular tone again, and therefore often will end up worse because of that active compression across sensitized joint tissue. So there's a manual therapy aspect to it. There's a educational perspective to it around pacing, etc. Boom and bust is a big thing with these people, because ultimately their bodies let them down. And if they're having a good day, they want to get all the things done, but then it ends up flooring them for 2 weeks afterwards. So it's really, and they've worked this out, but often you just need to put it in front of them and say, look at this pattern of events over time. And then exercise is a really important element, but the exercise prescription is not, again, it's not your recipe based. This is the diagnosis of, let's say it's a patella subluxation. Your textbook progression of exercise, your textbook timelines will be different. It will be a longer recovery. These people do not build muscle strength, grunt as quickly as the non-flexi population, especially in the female cohort within this group. And there is literature on that's accessible. The exercises are often really, again, you've got to take sideways steps and play around with foot position, hand position, body position, cueing strategies, because their recruitment patterns will be different. And from a physio, it's often a case that these people have been blamed for not adhering to their exercise programs and therefore not making progress. Whereas often it is they've been started with too high a bar, or the progressions are too big. You've got to, from your non-flexi patient, you're going to have 10 progressions in between for what someone that's non-flexi would have one. So it's a much more nuanced, you've got to listen, you're slower paced, but it will make a difference. And that's the key. It's a long ball game. It's not a quick overnight fix.
So Leanne, you've given us great insight into the approach from a physio, and Jason, you've mentioned some of the medications you might try, such as antihistamines or famotidine, nizatidine, low-dose naltrexone, amitriptyline, nortriptyline, gabapentin, and the like. But I imagine this is very much a multidisciplinary space in terms of managing these patients. So who else might be part of the team that should be recruited to help these patients, and how do you coordinate their care?
Yeah, so often, gut stuff is really prevalent, and so getting a dietitian on board is really key. There is some thought that part of the problem with hypermobility Ehlers-Danlos syndrome is that it's protein synthesis type problem, and so actually, if we can increase their protein intake, that may help, and it'll help them with their physical rehabilitation with the physiotherapists, and that sort of thing. Diagnoses like ADHD and autism are common, and so if that hasn't been addressed, so I definitely try and get that looked at. I think a psychologist can be very helpful. We know that medical trauma is experienced by something like 89% of this population, and also in autistic and ADHD populations, trauma is huge. So PTSD, CPTSD are all really common aspects. And then also the challenges of managing chronic disease. This is an incredibly tough thing to live with. So I think having a psychologist with experience with chronic disease, with neurodivergence, if that's part of it, is really, really key. And I must emphasize, I'm not sending them because I think that, their primary problem is anxiety. We're not saying that, but they can help with, well, how do you manage life with energy limiting conditions, with pain limiting conditions, with neurodivergence, with trauma? So I think they're really kind of important. And then it really depends on the individual. Like there's a picture on the Ehlers-Danlos website about the spectrum of presentations. It depends what they present with. If headache is a huge thing, then we'll go down, the migraine headache, maybe they require headache neurologist. If the gastro is really prominent, maybe we need a gastroenterologist. POTS and dysautonomia is really common. Sometimes we need cardiologists, but then again, I would also say that as GPs, we are also perfectly capable of identifying and managing these conditions. Like say, for example, POTS, it's a nasoline test. We can do that. The medications are simple, they're safe. We use them all the time in other populations. So I don't think we need to be worried about it. The Canadian Consensus Guidelines is absolutely fantastic. It lays out how do you diagnose it? How do you treat it? These are your first line, second line. Because again, cardiologists, there's an access barrier to that. So an exercise physiologist can sometimes be really helpful. Sleep disturbance, forgot, huge, so common. And so sometimes having a sleep physician, again, with experience in these sort of conditions can be really helpful. So yeah, it's really that kind of classic GP role. Like we want to look at them as a whole person. What are the things most troubling for them? What is limiting them? And then we address that. There are some tools which can help, like the SPIDER tool, which helps map multimorbidity or multi-system type conditions. And so that can sometimes help you prioritize, because they might say, yeah, look, pain is a problem, but actually I can't stand up. I can't stand up for more than 20 minutes. So actually, maybe that's what we need to focus on. Or maybe it's the gut, and, the orthostatic stuff is not such a big deal. Yeah.
So this is where GPs come into their own, really, as fantastic coordinators of care. And I guess there's tools we can use to assist our patients being able to access all the multidisciplinary care with care plans and allied health referrals to dietitians, psychologists, exercise physiologists, and so on. Leanne, can you comment on the importance of patient advocacy and support networks in trying to improve outcomes for patients living with EDS and HSD? What sort of support groups and education centres are out there for patients to help them learn more about their conditions and also to find the support they might benefit from?
Well, I guess just touch on the first part about the importance is that the fact that these people are or typically, again, statistically, have had a journey where they've been fighting for a diagnosis and joining the dots for years and years. So to have organisations and groups that they can resource to know that they're not the only ones that are out there experiencing these things is a really positive element to what they can access. Connective Tissue Disorders Network Australia, CTDNA, is a recently established charity organisation which is doing an amazing job at driving the bus to drive change in this space and improving both diagnostic and outcome pathways for people with heritable connective tissue disorders. And so they are building their online resource and drawing on many volunteers, both in the medical and allied health space, but as well as the lived experience space of different skill sets to improve awareness, improve education, and therefore improve outcomes. And then support groups. Well, and another access point is the Ehlers-Danlos Society website, which again has an evolving resource list of things for both those with lived experience as well as practitioners that want to learn more. And then your social media groups, obviously with judicious assessment of the information that you're digging into in that space, but they can be really great just in terms of, again, it's that validation. You're not the only one. This is real. The struggle is real. This is a tough gig. And so they're also very accessible, and there's many of them, and some, it can go both ways. And I have had many of my clients step away from those spaces because sometimes it can be you've got to take what you need from those groups, I think, and leave the rest behind, is what I'll say in that space. Yeah.
So we've covered a lot, and thank you so much for sharing your expertise and insights on this topic. I think it's so important that GPs have a greater awareness about conditions such as Ehlers-Danlos syndrome and hypermobility spectrum disorder, so that we think of it, particularly in patients who may be presenting with undifferentiated pain type syndromes, or as you've talked about, GI symptoms, POTS symptoms, gut symptoms, headaches, and so on. So could you offer any sort of takeaway messages for our GP listeners today?
Mine, I guess, is that there is a clinical responsibility, I feel, here for both, GPs as well as allied health across the board, in that the prevalence of these conditions is more than is stated in the literature. And with that suspicion of 1 in 500, it's common. It would be guaranteed that every GP would have someone that has an undiagnosed heritable connective tissue disorder on their list, and they're flying around under the radar, not appropriately managed, and they're suffering for that. So the other part of the Ehlers-Danlos Society website is there is a practitioner list as well in that space. So in being aware, it's also knowing who is around you within your region who may be able to cover certain aspects of these presentations as well. And that list on the Ehlers-Danlos Society website covers both medical and allied health domains. And I guess to consider that just because you can't see something on scans, as Jason said, and just because there's nothing coming up on the tests as we have today, it doesn't mean that this person's symptoms don't exist. There's a lot that we don't know in this space. I think the more you learn, the more you realize you don't know. And so please be open-minded when something's puzzling you and there's lots of dots to join, that it is potentially a connective tissue disorder, and that it is something to explore and consider. Even if you're not an expert, being aware and knowing who to resource and where to resource information can be helpful. And as Jason said, if someone presents thinking that they have it, pretty much it's a high likelihood. Information is accessible, and patients who have been dismissed for a long part of their life with their health journey, they dig and they explore and they talk and they read literature and they identify with it. And if they're coming to you saying this is I think what is going on for me, your ears should prick and you should respect that insight.
They're great messages. Thanks, Leanne. And Jason, any closing comments from you?
I think that covers it beautifully. It is common. It is much more multi-systemic than I guess we often think about. Their bendiness might not be the biggest problem. They're bendy, but it's all the other stuff. So yeah, having that broad exploration and understanding of the patient and where they're at across all the systems. And one of the interesting things which I didn't get to mention before was that sometimes they have so many problems that they don't even recognize some of them as problems. So yeah, keeping your ears pricked and then exploring further. And I think, really, I'd really love GPs to step up here. This is where we shine. We are the multi-system experts. No one else covers every system across all age groups, So I think we can really play a strong role in the identification, in the diagnosis, and the management and the case coordination of these conditions. I'd really love for GPs to kind of get inspired on this. And there are resources out there. I know I'll give a plug to Dr. Megan Thomas. She's got a fantastic website with a bunch of resources on it. I will also have some, but I'm lazy and disorganized, so my page isn't up yet, but hers is up and it's great. I've got an article coming out in How to Treat. Megan's got one out in AusDoc. There's a pediatric one which came out 2 years ago in the Australian Journal of General Practice. So there is stuff out there. Look it up. Yeah, like Leanne said, keep it in your mind. Patients are incredibly well informed now, and believe them. I guess that's the other really key thing. Their experience is real. Just because we can't see it on tests, just because we can't image it, doesn't mean their symptoms, their experience isn't there. I think we all now believe that chronic fatigue, myalgic encephalitis, is a thing. I think hypermobility and these conditions are that. We're just 10 years behind. So let's not wait 10 years. Let's get onto it.
These are great messages. And as you mentioned earlier, no single specialty owns this condition. And it's an area where GPs could really shine, recognising, diagnosing and helping to establish referral networks of EDS-aware practitioners. As you suggested, Leanne, we could obtain information about allied health practitioners and other doctors who have an interest in this area through both ctDNA, the Australian Peak Body for Connective Tissue Disorders, and the International Ehlers-Danlos Society. This can help GPs who may not yet have the confidence or expertise in this area to build effective referral pathways and ensure their patients receive coordinated, ongoing management and support, something GPs already do so well. So Dr. Jason Lamb and Leanne Scown, thank you so much for joining me on today's Health Ed podcast and for sharing your expertise and insights on such an interesting topic. I value your time. Thank you.
Thanks so much for having us.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.